인턴 및 레지던트 과정을 마치고 현재 시니어 클리니컬 트레이닝 스컬러로서 소동물 내과학을 담당하고 있습니다. 댄 톰슨 수의사는 오늘 강의에서 개에서 췌장염의 원인과 여러 진단법들의 비교, 수액 및 약물 처치, 그리고 영양학적으로 저지방 시기를 이용한 관리 방법에 대해 자세히 설명해 주시겠습니다. 그리고 로얄캐닌 영국의 리당 수의사가 강의 중 퀴즈 진행과 강의 후반부의 췌장염 관련 제품에 대한 설명, 그리고 질의응답을 진행해 주시겠습니다. 본 강의는 8월 8일 영국에서 방송되었던 로얄캐닌 웨비나의 녹화 강의이며 강사의 음성과 PPT 화면만 방송되며 강의 시간은 약 1시간 반 정도입니다. 오늘도 강의를 끝까지 들어주신 분들께 커피 모바일 기프트 카드를, 특히 올해 5번의 로얄캐닌 웨비나에 참석해 주신 분들께는 크리스마스 케이크 쿠폰을 보내드릴 예정이니 끝까지 함께 해주시기 부탁드립니다. 접속이 잘 안되시거나 시청에 문제가 있으시다면 우측 대화창에 있는 전화번호로 연락 주시기 바랍니다. 그럼 오늘 웨비나를 시작하도록 하겠습니다.
Good evening, everybody. Thank you for being here today. I hope you're all sat nice and comfortably with a nice cup of tea or a glass of wine for our meander through the up-to-date thinking on pancreatitis in dogs. So just a little bit of housekeeping from me. Thank you to Lee for his introduction. He's going to go through all of the technicalities for the Royal Canin diets at the end. By way of disclosure, I'm not employed directly by Royal Canin, but my residency scholarship is very kindly funded by Royal Canin, and therefore it should be no surprise that a number of Royal Canin products are likely to feature in this presentation. As we go through, we're going to play question and answer now and then, and if anybody has any questions, then please do feel free to send them through and we can take a look at the end. So, it's impossible to start an internal medicine presentation without a little bit of physiology and pathophysiology. Now, I love a bit of physiology, but I know it's not exactly shared by everyone, so I'll try and keep it fairly brief and need to know. So as we all know, the role of the exocrine pancreas is to produce digestive enzymes that are released from the pancreatic ducts into the duodenum. These enzymes are produced within the pancreatic acini as inactive forms known as zymogens, which sit in protective vacuoles within the pancreas until they're stimulated to be released. This stimulation can be due to food in the stomach, or the thought of eating, or the process of eating. And once the inactive enzymes reach the duodenum, they are activated by a combination of the decrease in pH, so the acid from the stomach, and by lysosomal and luminal enzyme-mediated cleavage. Now, pancreatitis occurs when the activation of these digestive enzymes happens within the pancreatic acini. More specifically, the final common pathway for the development of pancreatitis appears to be the activation of the zymogen trypsinogen into trypsin. And once activated, the trypsin can begin to auto-digest the pancreatic tissue. And this process can cause some serious and severe, even fatal, inflammation. Now, the pancreas has got plenty of ways of trying to prevent this happening. The trypsinogen zymogen is normally kept spatially separated from the activating lysosomal enzymes within their own vacuoles to prevent activation. The pancreas also secretes large amounts of bicarbonate to keep the pH nice and high to reduce the likelihood of activation. There's also a handily named enzyme, pancreatic secretory trypsin inhibitor, whose role is to hang around within the pancreatic acini and mop up any escaped trypsin that's prematurely activated. Only when these protective measures have been overcome can enough trypsin build up to begin the process of autodigestion and inflammation. This trypsin can then activate further trypsinogen and other enzymes, leading to a snowballing process where we see the acute severe systemic inflammation that can prove fatal in some patients. But why does this happen? Well, the honest answer is that we still don't know for sure. There are various theories. These include failure of the normal mechanisms of breakdown of the excess enzymes and lysosome within the acini, leading to buildup, or development of what's called an apical block, whereby the enzymes and the lysosomes can't cross out of the acini into the pancreatic duct and therefore build up within the cell. But whatever the cause, this does appear to be the final common pathway in the development of pancreatitis. What we do know is that there are a significant number of suspected and confirmed predisposing and inciting causes. These include diet, various drugs like potassium bromide and azathioprine, endocrine diseases like Cushing's disease, pancreatic hypoxia as a result of hypovolemia or congestive heart failure, or triglyceridemia. There's also a genetic predisposition. So in the UK, particularly cockers and cavaliers and boxers appear to be predisposed, whereas elsewhere in the world, breeds like miniature schnauzers also appear to be predisposed. And there's also some evidence that some breeds of dog, particularly Cocker Spaniels, might have an autoimmune form of the disease as well. Now, we'll look at some of these more closely as we carry on through the presentation, but we do know that pancreatitis is a very multifactorial condition, and therefore the presence of one or more of these predisposing causes doesn't guarantee an individual patient will develop clinically apparent disease. Why a particular individual develops pancreatitis and another doesn't remains a mystery. Now, there's one technicality that warrants clearing up before we dive into the real clinical stuff, and that's the difference between acute and chronic pancreatitis. Often we make the mistake of assuming that anything where the clinical signs appear over a short period of time must be acute, and anything that grumbles on for a longer period must be chronic. Unfortunately, this doesn't really hold true for pancreatitis. By way of example, a dog that presents acutely for the first time might have acute pancreatitis. Alternatively, it might have had chronic subclinical pancreatitis for many years, and therefore might just be having an acute on chronic episode. Equally, the dog that presents for the second time might be expected to have chronic pancreatitis with an acute flare-up. But it is also possible that they simply have a second acute episode without any chronic changes. Or it's possible that a previous episode was acute and resolved, but that the chronic changes have now occurred and this episode reflects an acute on chronic episode. It's all rather confusing. Why is it important? Well, if we look at acute pancreatitis, this is actually defined histologically as inflammatory changes with usually a neutrophilic infiltrate, edema, and possibly some necrosis. There is no evidence of chronic change or fibrosis in these cases, and the pathophysiology is potentially completely reversible. At the end of an episode, we're left with an entirely normal pancreas, and if they don't have another episode in the future, then they shouldn't have any further problems. In chronic pancreatitis, we tend to get mononuclear inflammation with development of fibrosis. These changes are not reversible and can cause a reduced functional ability of the pancreas with respect to both its exocrine and endocrine functions. And by that we mean the potential development of exocrine pancreatic insufficiency or diabetes mellitus, both of which we need to keep an eye on. Without histology, it's impossible to know which of these we're dealing with, and therefore the danger is to assume that our flare-up is acute only and not worry about things like diabetes and EPI. Instead, rather than labelling them clinically, it would probably be wise to treat all acutely presenting cases as acute with respect to immediate management, and then monitor and manage them all as though they're chronic. And that's really how we're going to proceed with regard to the rest of the presentation today. So, on we go with diagnosis, and where better to start than with signalment. So, the classic dog that presents with pancreatitis is going to be middle-aged to older. That said, pancreatitis can occur pretty much at any age, and actually reports in the literature find dogs as young as a few months of age all the way up to diagnosis at the ripe old age of 15. In truth, though, the vast majority of dogs will be over 5 years old, with younger dogs only representing a really small fraction of cases. And so although your dog with vomiting or diarrhea might have pancreatitis, if it's young, it should probably be a little bit lower down on your differential list. Now, breed is another really big thing. Pancreatitis can technically occur in any breed of dog, but predisposition due to breed is pretty well demonstrated. In UK populations, as we've already said, the common breeds are Cavaliers, Cockers, Collies, and Boxers. but other geographical regions do have different predisposed populations, and it's likely that these diseases might also have some overrepresentation here. Miniature schnauzers are particularly more likely due to their genetic propensity for idiopathic hypertriglyceridemia, which is one of the risk factors. On the other side, there are also other breeds such as greyhounds and other sighthounds who appear to be significantly underrepresented, and therefore in those breeds pancreatitis is potentially much less likely. Moving on to history, again we have a potentially huge variety of possible presentations, but we'll focus here on the patient that presents acutely, either for the first time or as a repeated or acute on chronic flare-up. So your common clinical signs are going to include anorexia, vomiting, weakness, abdominal pain, dehydration, and diarrhea. These are listed as the most common, but there are plenty of others that you might come across, including jaundice, pyrexia, hypothermia, bleeding, and ascites, and in some of the more severe cases you might also come across things like shock, DIC, and multi-organ failure. Moving on to clinical exam, most of the clinical examination is going to be dependent on the severity of the disease and the previous duration of clinical signs. For example, if your disease is fairly mild, then you may find your clinical examination is completely unremarkable. And so if you find that, it certainly doesn't exclude pancreatitis as a possible etiology. In more severe or longer duration conditions, then you might start to find things that reflect both abdominal discomfort and or dehydration. The classic cited observation in these dogs is the prayer position. For anyone who hasn't seen this, then I found a nice picture of a dog demonstrating this. There's sometimes an assumption that this position is kind of pathognomonic for pancreatitis, but unfortunately that's not really the case. And this can really be a sign of any kind of abdominal discomfort. And so other classics that you really don't want to miss are going to include things like GI foreign bodies, septic abdomens, that kind of thing. So don't be fooled jumping straight into pancreatitis if you see this. Other signs of pain on exam might include a tense abdomen on palpation, particularly cranially or crying on palpation, and then general signs of pain like tachycardia and mild to moderate increases in rectal temperature. Other signs you might see are going to include things like hypersalivation as a result of nausea and evidence of dehydration with tachymucous membranes and reduced skin elasticity. Okay, so your patient walks in. Let's say he's a 7-year-old male-neutered Cavalier King Charles Spaniel. His owner says he's been vomiting for 48 to 72 hours and he's become progressively more and more lethargic. He's got tachymucous membranes, tense abdomen, and borderline increased temperature. Now, watching that dog walk through the door, I'll admit there is a renegade part of my brain that's already trying to pigeonhole that dog straight into the pancreatitis box. He fits the signalment, he fits the classic clinical signs, and so there's always going to be that temptation to allow ourselves to bias our investigations towards what we're expecting to find. But this is a bit of a dangerous game where pancreatitis is concerned, partly because there are so many other possible differentials for this presentation, and partly because pinning down a definitive diagnosis of pancreatitis is invariably a real challenge. Now, I'm not going to do you all the disservice of reading out a list of differential diagnoses for acute vomiting, because you all know this already. But we'll flash up a list quickly, partly for effect and partly to demonstrate the need for a thorough diagnostic approach going forwards. So, with that in mind, clearly we need to be considering a fairly broad initial diagnostic approach. The reason for this is twofold. One, we need to not miss that GI foreign body or that Addisonian or that PIA or ketoacidotic diabetic, as missing those isn't going to end well for any of us. 2, as previously alluded to, pancreatitis is not a straightforward diagnosis. In fact, to be honest, it's almost a diagnosis of exclusion. And therefore, to be secure in our final diagnosis, we have to cross off a lot of stuff on our way. So here's question 1. There's not really a single right answer, although I would have some fairly strong preferences. Really, this is just to test the question answering process. So we have a 7-year-old male neutered Cavalier King Charles with a 72-hour history of vomiting and progressive lethargy, fully vaccinated with a tense abdomen on palpation and dehydrated and borderline pyrexic. What is going to be your first move?
So Dan's got some particularly challenging questions, as I'm sure is already obvious to everyone. All you need to do in order to vote for this question is just select directly on your screen the corresponding answer. So how would you clinically approach this case? I can see, Dan, that 31% of people, and growing, are interacting with you nicely. I'll just leave the poll running for a minute or so and then close it and share the results.
More the merrier.
Yes. And they are polarised nicely. And in these breaks you can have a drink and a rest, Dan. Okay, I can see that close to 70% have voted, so I'm going to close and then share the results with everyone there. Dan, I can see that 1% selected the first, meropitant and SQ moxicillin, and send home. 33% admit for fluids and pain relief. 53, so the larger reply there, in-house biochem and haematology. 12% went straight for X-rays, ultrasound, and 0% endoscope and XLAP. Or XLAP. We put those two answers together.
Well, I'm comforted by the lack of number of people who've gone for endoscopy or XLAP in the first instance. So I kind of agree with you guys, really. I would certainly start with a biochemistry and a haematology with or without imaging. To be honest, I wouldn't say there's anything wrong with starting with some fluids and pain relief, as long as you've got a decent means to monitor these guys while they're in. So, obviously this webinar is about pancreatitis, and so we're going to carry on from here with the results we might expect from a dog with pancreatitis. Now, as I said, my first step is going to be bloods, and initially it's going to be a biochemistry and a haematology. So what biochemical changes are we possibly going to see in a dog with pancreatitis? Well, they can be fairly non-specific, to be honest. Most of the common ones we see are things like mild to moderate increases in liver enzymes, and it can really be any pattern of increases in these, and they're often thought to be reactive secondary to the pancreatitis, or can be related to the underlying cause of the pancreatitis. So things like hypovolemia and hypoperfusion of the liver can also cause the same in the pancreas and can cause increases in liver enzymes. We might see an increased total bilirubin. We might see azotemia, which is going to be commonly pre-renal as a result of systemic dehydration. But on occasion, it can also reflect concurrent renal disease. Other plausible findings include hypoalbuminemia and hypertriglyceridemia and hypercholesterolemia, which have been suggested as possible causal or risk factors for inciting pancreatitis. And we might also see electrolyte abnormalities as a result of the ongoing vomiting and reduced food and water intake. And so most commonly, we might expect hypokalemia, hypochloremia, and hyponatremia. In some of the more severe cases where we have acute necrotizing pancreatitis, we sometimes see low calcium levels, hypocalcemia, as a result of saponification of peripancreatic fat and mineralization of calcium within this fat. You might also see increases in general inflammatory markers such as C-reactive protein. And in those really severe acute cases where the systemic inflammation is really profound and we have a risk of DIC, we might even start to see prolonged clotting times, which you may or may not be able to measure in-house. And then there's hematology. These are also pretty non-specific. You might see some hemoconcentration or anemia. You might see white cell changes in either direction, and you might see reduced platelet numbers as a result, again, of severe disease and DIC. Now, although the changes are really non-specific, it's still worth getting the information, both for monitoring purposes and for assessing hydration status, and also for checking for underlying kidney disease, that kind of thing. Now, we'll mention urinalysis only very briefly, because there's not really any findings remotely specific for pancreatitis. However, it is going to be an important information source for any animal with clinical signs of an acute abdomen. Firstly, we've said azotemia is fairly common and that it's usually pre-renal. You can confirm that nice and easily with a USG, which is helpful, cheap and cheerful. Obviously, you must get your sample prior to starting fluids, which is why I mention it here. Secondly, pyelonephritis and glomerulonephritis are on a differential list, and so a dipstick and sediment and culture is great information to have to look at the likelihood of this. And the same goes for diabetic ketoacidosis for glucose and ketones. You can also look at your urine protein creatinine ratio. Now, pancreatitis is an inflammatory disease, and systemic inflammation can cause protein loss into the urine due to effects on the perm selectivity in the glomerulus. So an increased UPCR can be quite common, but it can also be associated with lots of other diseases, including urinary tract infections, pyelonephritis, Cushing's disease, amyloidosis, hypertension. The list is pretty long. And then next on the list of our fairly non-specific tests is going to be abdominal radiographs. Now, radiographic sensitivity and specificity for pancreatitis is fairly appalling. In fact, one study found a sensitivity of 24%, and the conclusion is that radiography has no value whatsoever in the definitive diagnosis of pancreatitis. That said, it should still be part of your workup if things like obstructive foreign bodies are on your differential list. And so, again, we mention it briefly before we move on to the big guns of pancreatitis diagnosis. So common findings on abdominal radiographs in dogs with pancreatitis include increased soft tissue opacity in the cranial abdomen, more so on the right. There's also typically a reduction in serosal detail in the same area. There may be displacement of the stomach and duodenum from their normal positions, and gaseous distension of bowel loops adjacent to the pancreas have also been described. There may also be evidence separately of abdominal fluid. Now, there's a small example here. In fact, this is a cat, because this is what I could find easily on our database. But you can see the loss of cranioventral serosal detail nicely on this image. But it's certainly far from specific for pancreatitis. So we move on to question 2. We need to confirm our diagnosis, i.e. we need to perform some specific tests for pancreatitis. Now, before we jump into that, I thought we'd have our second question. I want people to be as honest as they can be, because it's completely anonymous. So the question is, when diagnosing pancreatitis in practice, after which of these tests or combinations of tests, in addition to the baseline bloods and radiographs and urine, etc., which we've already discussed, which of these, if the results were positive, would you be routinely happy that pancreatitis was the final diagnosis, and that you would stop investigations and start treating?
People are a little bit slower off the mark with this one, Dan. Hopefully you haven't lost anyone with that immediate complexity, but no, I've got 50% voted.
I'm sure we can manage more than that.
Yes. And I've got some really nice questions coming in as well for the end, so please all do remember to give us some questions to keep Dan talking for as long into the evening as we can. Okay, so I've got around about 70% or so voted, so I'll close that poll. And sharing the results, I can see that 1% have voted for your first option there. Once again, consistent history and clinical signs. 6%, option 1 plus increased serum amylase and lipase, 27%. So the second highest, option 2, IDEX SNAP, CPLI. 22% have voted for option 2 or 3, and quantitative send away spec CPL. And then 44% all of the above plus ultrasound. So 44% for number 5 being the highest result.
Lovely. So that's really interesting. That's a nice mix, and it gives us a reasonable amount to talk about while we carry on through. I did have one more question before we go ahead and talk about specific tests. So question number 3 is, if you don't have these tests available in-house, which of these quantitative assays for markers of pancreatic inflammation would you choose to send off for with your external lab?
Great. So polling is once again open there. On your last question, you had a couple of flurries of reactions to amylase and lipase. So I know that there's a lot of questions related to those, which I can see that you are going to follow up with in the next slide. But we do have 70% or so voted now on this question. So I'm going to close this poll. And you've got a vast majority voting for spec CPL, 84%, but 5% went for serum amylase and lipase, 8% TLI, 84% once again the specific pancreatic lipase, and DGGR lipase 3%.
We'll start with the old guard. So most practices these days probably have the ability to measure in-house amylase or lipase or both. These are the original assayed markers of pancreatitis and have been around now for over 40 years. But despite this, we've hunted and hunted for alternatives for diagnosing pancreatitis. And this fact alone should probably give you some idea of how reliable they're likely to be. And here's why. So assays for serum amylase and lipase are not specific for amylase and lipase of pancreatic origin. In fact, it's still really uncertain as to whether there is even a pancreatic-specific amylase or whether all amylase is just the same, unlike in lipase where we know that there are different isoforms. As well as the pancreas, you'll find amylases and lipases in saliva, the liver, the gastric mucosa, the intestines. In fact, these enzymes are produced elsewhere to the extent that one study showed that if you remove the pancreas completely experimentally, there's no significant change in the basal levels of serum amylase or lipase. So there's plenty produced elsewhere. When they are increased, the assays just detect them all the same. So even when increased, amylase and lipase may not reflect pancreatic inflammation, which is not great for test specificity. On top of this, they can also be increased by other disease processes, such as renal disease, hepatic disease, intestinal disease, neoplastic disease, and also by steroid therapy or Cushing's disease. Overall, sensitivity for these is really poor. In fact, studies have found it to be as low as 14% when we use histopathology as a gold standard, which means if you're relying on your amylase and lipase, you might miss up to 86% of the cases, which is quite a lot of the cases. Specificity has been reported to be around 50% on multiple occasions, which means effectively, if you do get a positive result, you may as well toss a coin as to whether the dog has pancreatitis or not. And so all of this together gives very little clinical value to these parameters. And they really, these days, they can't be recommended as markers of pancreatic inflammation. Now, moving on forwards a little bit in time, we reach TLI, or trypsin-like immunoreactivity. TLI is a parameter many of us measure relatively frequently as a marker of pancreatic disease, and theoretically it should be well suited to this, as there's good evidence to suggest that trypsinogen and trypsin are only manufactured in the pancreas. That makes it a great marker for exocrine pancreatic insufficiency, EPI, because if your pancreatic function is gone, there won't be any enzyme production from anywhere else, and your result will be low. It's a nice test. But what about for pancreatic inflammation? Well, the theory here is that when the pancreas is inflamed, the trypsin and trypsinogen are released into the systemic circulation. Some of this that's released is mopped up by enzymes like the alpha macroglobulins, which exist just for this purpose. But if they're released in sufficient volume, the trypsin enzymes will overcome the capacity of these macroglobulins and will start to build up in the blood. And therefore, if we measure them in pancreatitis, they should be high. And to an extent, this holds true. In some cases of pancreatitis, a high TLI level can be detected. But this isn't without problems. Problem number one is that although TLI will increase with pancreatitis, it actually often reduces back to normal within about 3 days. That means that if you only measure on day 3 or day 4 after the dog first showed clinical signs, it might actually have got back to within the reference range. And this is a problem because it affects our sensitivity of our test. And actually, the literature tells us that the sensitivity for TLI is only roughly 36 to 47%. And actually, a recent study found it to be as low as 7% in mild pancreatitis and only 29% in moderate pancreatitis to severe. Even taking the higher results, if you get a negative test result, so a result within the reference interval, you're missing over half to 2/3 of the cases. And if you use this as your tests, if you use this test as your definitive test, then that's quite a large proportion to miss. But what if it's positive? Does that mean we have pancreatitis for sure? Well, unfortunately, we fall down there too a little bit, because although pancreatitis will cause increases, and although it's not produced anywhere else, there are still other causes of increases. The main issue is that trypsinogen and trypsin are excreted by the kidneys. That makes their excretion a function of glomerular filtration rate, GFR, and that means that anything that can reduce GFR can increase TLI. Now, the classic causes are going to be concurrent renal disease, and certainly this has been shown to increase TLI, but it also means that any disease that causes dehydration and a pre-renal decrease in GFR can also increase TLI. Now, this is bad for our specificity, as many of the conditions on our rather long differential list from earlier will potentially cause dehydration or reduce GFR. Some papers have found the specificity up to be up to 100%. Despite this, however, that might well be a reflection more of the studies than of the TLI assay itself. And actually, it's probably worth touching on study design very briefly before we go any further, not because it's at all interesting for most people, but because it actually makes quite a big difference in our understanding of our own tests, certainly in pancreatitis. So, briefly, to calculate a sensitivity or a specificity of a test, you have to be able to compare that test to a gold standard test, i.e. a test that gives you the definitive diagnosis for the disease. To take an example, for Addison's disease, the gold standard test, as you all know, is going to be an ACTH stimulation test. And if you wanted to work out the sensitivity for, say, sodium-potassium ratios less than 27, you'd compare the results of those to the results of your ACTH stimulation test to decide what are true negatives and positives and what are false negatives and positives. The problem with pancreatitis is that we don't really have a good gold standard. The classically used gold standard has been histology, but that presents a few problems. The first is that no one ever takes pancreatic biopsies of dogs with acute pancreatitis. It's just not necessary, and it comes with high risks. And that means that data is not really available for us to compare with blood tests in clinically affected dogs with naturally occurring disease. The second problem is that in histopathological studies that have been performed, a very, very large percentage of normal asymptomatic dogs with no clinical history of pancreatitis will have evidence of inflammation in their pancreas histologically. One study found that 34% of dogs, irrelevant of what disease or lack of disease they had evidence of pancreatic inflammation at histology, which is 1/3 of all dogs. That being the case, we then have to ask ourselves if the lesions that we find histologically are a true reflection of clinical pancreatitis in our patients. The honest answer is probably not in a lot of cases. Now, what does using this as our gold standard do to our sensitivities and specificities for our test? Well, to cut a long story short, this style of study is likely to do a few things. It's likely to artificially increase our specificity, because if you get a positive result, it's more likely to be backed up by histology. And our sensitivity is going to be artificially decreased, because a negative result may very well still have histological evidence of pancreatitis. As we said, a third of them do, and therefore might be judged a false negative. On the other hand, inflammatory changes in the pancreas are often very localized. And so it's also possible to miss lesions within the pancreas on histology, which will artificially decrease our specificity. So that's a problem. The other study style involves cases being selected for the definitive pancreatitis group based on a number of experts reviewing cases. This is done without access to the specific pancreatic test that they're measuring. And these cases that they select are the ones that are definitively diagnosed as the gold standard cases. Test results can then be analysed and sensitivities and specificities calculated based on this gold standard group chosen by the experts. The flaw here is fairly obvious, and that's that whether or not the dog had pancreatitis is still a matter of opinion. Often these cases have had different workups by different people, with or without some imaging modalities, and so the reliability of this as a gold standard group has to be very questionable. Another problem. But the biggest problem of all is that we design our studies like this not for convenience, but because it's the best we've got. We've not got a good gold standard for pancreatitis. Now, this doesn't mean that what we get as results for all of these tests when we try to analyse them is rubbish, but it does mean that the headline results might not be quite as they seem, particularly with respect to some of the very high reported specificities of the tests we're about to discuss. So, moving on to the test that the majority of you would choose to send off, which is the IDEX SPEC CPL, specific canine pancreatic lipase. Now, this is probably the most commonly used in general practice send-away test for confirming the diagnosis of pancreatitis. It's only available through IDEX because they developed and patented it, and it's almost universally agreed to be the most useful test for diagnosis of pancreatitis when you look at the literature. As its name suggests, it is an enzyme produced only in the pancreas, and so like with TLI, increases should theoretically relate to release from the pancreas only. It's an enzyme-linked immunoassay, or ELISA, and uses two different antibodies to detect the SPEC CPL, which is all well and good. Now, SPEC CPL has three possible ranges that your result can fall into. The first is the normal reference range, so the negative or the no pancreatitis range. And this ranges from 0 to 200 micrograms per litre. Above this, there is an inconclusive region, or equivocal or grey zone, which exists between 200 and 400 microlitres, where the dog may or may not have pancreatitis. And then anything above 400 is considered consistent with pancreatitis, up to a detectable limit of around 1,000 micrograms per litre. Now, this is the test that's had by far the most work done on it, with multiple studies of multiple designs looking at sensitivity and specificity. These have produced a predictably wildly different results, which, as we mentioned before, is probably mainly down to study design. That said, though, CPLI does consistently get the best sensitivities and specificities of all the biomarkers, and so there's little doubt at the moment that this is the best test that we have. Now, many of the studies calculate the sensitivities and specificities based on both the 200 and the 400 microgram thresholds, and the differences that we get in these results can go some way to explain why we have a grey zone. So let's take a quick look at those. Now, I'm not going to go through all of them, as it would take a really long time, and it's not particularly interesting for most people. That said, if anyone would like the full references for any of these papers at the end, or if people have specific questions, then I'm more than happy to deal with them as well as I can once we go through. I would like to draw your attention to a couple of things, though. which the first is the variability in results. Sensitivities for the 400 microgram per litre limit, so the diagnostic limit, go from all the way up high at 78% down to 21%, and the specificities go from 81 all the way up to a rather unreasonable 100. Note the reduction in specificity, so the number of true positives when the test says it's positive, when we reduce it to a 200 microgram threshold. We get all the way down to 66% in one study. This explains why they have a grey zone, so the doubt, and it will also become fairly important later on when we discuss some of the other tests. This is also a really nice illustration of study design that we've just discussed. So if you note that the two studies that use the clinical criteria show the predictably higher sensitivities and the predictably lower specificities. And I'd like to highlight two of these very quickly because I think these are the two that are most likely to be the reliable indicators of what the actual results of the sensitivity and specificity for this particular test are. So these two papers both use the clinical criteria, so the expert panel. So history, clinical exam, routine bloods and urine, ultrasound if available, were used to assess the symptomatic patients to decide whether they have pancreatitis or not. So this panel is effectively reviewing the cases as a whole to decide if they had pancreatitis or not. They were blinded to the results of the SPEC CPL. Now this is far from 100% reliable, but it makes considerably more sense to me to assess the usefulness of these tests in the context of real cases of pancreatitis, because they're being compared to other cases with acute abdomen. So you're not comparing known pancreatitis to normal dogs, you're looking at a pool of dogs that present with acute abdomens. So as far as I'm concerned, for looking at accurate sensitivities and specificities, these are likely to be more accurate, and you can see that our sensitivities are kind of between 72 and 78, and our specificity is kind of around the 80%, maybe a little bit higher mark. Now, there is another reason that I think that these papers are more likely to be reliable. If we take a look at the specificities of the 400 microgram histology papers, they're sitting pretty near 100%. Now, I don't know about you. I've known plenty of occasions where I've had test results come back that just don't seem to fit with my clinical presentation. You've tested it because you feel you ought to, but it doesn't quite fit. And you find there's something else going on. Now, a specificity of 100%, which we see in some of these studies, would imply that nothing else other than pancreatitis can possibly cause an increase in SPEC CPL. Unfortunately, the rest of the literature disagrees. So there's quite a lot of things that have been shown to interfere with SPEC CPL, including things like hemolysis, or not, sorry, interfere, including things like hemolysis, icterus, and lipemia. But there are a number of other conditions that do appear to develop or do appear to cause increases in SPEC CPL without clinical evidence of pancreatitis. Whether they develop mild inconsequential pancreatitis or whether there's induction of enzymes isn't known, but this is relatively inconsequential in a clinical scenario because obviously what we need to know as vets is what's causing the clinical signs. So non-pancreatic primary diseases leading to increased CPL include things like congestive heart failure, azotemia, Cushing's disease, phenobarbital, potassium bromide, obesity, hypertriglyceridemia, immune-mediated diseases, parvovirus, and diabetic ketoacidosis. All of these have been shown to some extent or another to increase artificially our SPEC CPL. So, although it's widely accepted to be the best that we have, it's not infallible. Now, one more quick vote, just for my interest really. A lot of you will, or I assume a lot of you will probably have access to this test, which is the IDEX SNAP CPL. And so I was just interested in terms of how many of you have, or what percentage of you have access to this test routinely within your practice.
Okay, so that poll's once again open, and they're straight off the mark. And a lot of complex questions coming through, Dan.
Oh, lovely.
Oh, yeah. So we have 70% or so voted. And to share those results, 70% yes, 30% no.
Okay, I guess that's probably about what I expected. I was used to having this test in practice before I went off to start the residency. And so it's interesting to know how many of you guys have access to this test as well. So to discuss the SNAP test, which is probably quite an important discussion, the SNAP test is based on the spec CPLI that we've just discussed. It uses the same reagents and the same theoretical reference limits. It's a patient-side serum test where you mix serum and the reagent that provide, place it in the well at the top of that picture, and then press down to activate the test. And after 10 minutes, you decide if it's positive or negative based on whether the sample spot on the right is lighter than or equal to or darker than the reference spot on the left. A positive result is indicated when the test spot, so the spot on the right, is darker or equal to the reference spot. Now, the threshold for a positive test is set at 200 micrograms per litre. So if we're remembering back to the range before, this is the top of the normal range, but the bottom of the equivocal range. That means that a negative result on a SNAP test is equivalent to an absolute negative on the spec CPL, but a positive result means that the patient either has high levels of spec CPL or is sat in the equivocal range. In other words, the dog might have acute pancreatitis or it just might not. Now, what about the numbers? Well, sensitivity in studies for acute pancreatitis has been reported to be pretty high. In fact, it's been reported to be kind of 82 to 94%, depending on which study you look at. Now, that's not surprising because we're including the grey zone cases as our positives in these studies. So that's going to reduce our number of false negatives because we're going to automatically kind of mop up a number of dogs in the grey zone as well. Specificity, on the other hand, could be expected to be lower for the same reason. And that holds true. Reports suggest that specificity is somewhere between 59 and 77%. What does this mean? Well, it means the SNAP test is really useful to rule out pancreatitis. A negative result is likely to be negative in kind of 90%, 9 out of 10 cases. But, and it is a big but, a positive result does not mean that your patient has pancreatitis. In fact, 4 out of 10 of them won't have pancreatitis. The SNAP test is a quick and easy and a convenient test, no doubt, but we absolutely cannot rely on it for definitive diagnosis without confirming quantitatively with the spec CPLI. It is tempting. I've been there multiple times myself, but remember, it is just a rule out. And if you need any more convincing on that, then IDEX themselves, who make the test, actually say exactly the same. And so for for those of you who in our poll a few slides ago went with the SNAP test results, then I would recommend quite strongly that if you do get a positive, that you still send away for that quantitative spec CPL, because that's going to be the thing that really reliably confirms your diagnosis for you. So, aside from IDEX's offering, what other options do we have? Well, we have a parameter called DGGR lipase. Now, this is based on a serum lipase, the original serum lipase assay, but it's much improved. It's been shown to have good agreement with spec CPL, the idea being that it can be used as a replacement. And the main reason this was developed is because IDEX patented spec CPL, and therefore all the other labs that many of us use weren't allowed to use it. So they've developed this assay to replace that, really, so they can have an alternative. Now, clinically, there are a few advantages to this assay, one of which is that it can be added to normal biochemistry profiles. So actually in the future, there's a potential that we can spread this out to you guys in practice as well. And actually, we use that quite commonly in Cambridge now. It's part of our normal biochemistry profile, and this is our standard marker for pancreatitis in dogs and in cats, in fact. We no longer really use SPECT-CPL unless there's a really, or unless there's some significant doubt. Other options include things like C-reactive protein. CRP is a marker of systemic inflammation and has no pancreatic specificity whatsoever. However, one study has suggested that it can be used for monitoring of patients for resolution as it returns to normal. And we tend to use CRP alongside other parameters like DGGR lipase to increase or decrease our suspicion of pancreatitis. There is also another pancreatic marker that's been investigated called pancreatic elastase 1. This has been shown to be relatively specific and sensitive for acute pancreatitis versus non-pancreatic disease. But it is unfortunately not currently widely available and therefore is not an option for us or for most people, to be honest, in practice at the moment. And then there are various other weird and wonderful things that are not commercially available and are beyond the scope of our discussion today, really, but that may become issues in the future. But for now, they're not really an offering. And then the last thing to discuss is our SPECT-CPL measurement on abdominal fluid. Now, there is one study that looked at this, comparing abdominal free fluid from dogs with pancreatitis to abdominal free fluid from dogs with other causes. They, interestingly, found a really high sensitivity and specificity for pancreatitis when they used a cutoff of 500 micrograms per litre of SPECT-CPL on the abdominal fluid. And actually, this may become a useful test in patients with possible pancreatitis and abdominal free fluid in the future. Unfortunately, it's yet to be validated properly. And so if you are tempted to use it, which would be a perfectly reasonable step if you have got abdominal free fluid, then it should be done in combination with a serum SPECT-CPL as well as your standard investigations. So the last thing I want to talk about before we move on to treatment and management is ultrasound. Now, it's probably fair to say that the majority of practices now have access to ultrasound in some form or another, and it can make up an important part of a workup for an acute abdomen. Pancreases have always been notoriously difficult to find on ultrasound, though. However, with advances in machine quality and expertise, it's becoming less of an issue, and certainly it is now relatively uncommon that the radiologists here in Cambridge are unable to locate and evaluate the pancreas, even in dogs without a suspicion of pancreatitis. There is a relative paucity of information available in the literature on the value of ultrasound. In fact, there's only really a couple of studies available. These have identified a sensitivity of a relatively low sensitivity of around kind of 56 to 68%. However, one of these studies is 20 years old, and so sensitivity might have improved in the intervening years. However, it is important to note that these statistics also come from board-certified radiologists. Ultrasound is a very operator-dependent and test, and is also dependent quite heavily on equipment quality. Personally, my ability to recognise and assess a pancreas on ultrasound is really poor, and I certainly would set very little store by my own pancreatic assessment on ultrasound. If you are a good ultrasonographer, unlike me, then things you might expect to find on ultrasound include hypoechoic and enlarged pancreases with or without a nodular appearance, hyperechoic peripancreatic fat, hyperechoic mesentery, abdominal free fluid. But equally, the pancreas in cases of pancreatitis may not be visible. Certainly in cases of chronic or end-stage pancreatitis, it can be incredibly difficult to track. So, moving on to treatment, we've hit the home stretch. There are some basic pillars of treatment for pancreatitis. The first 5 need to be considered really for every single acute pancreatitis case that crosses your threshold. And these are IV fluids, pain relief, dietary management, acute and ongoing, and gastroprotectants and antiemetics. There is one more thing that we'll mention briefly if we have time, and that is fresh frozen plasma. So this is kind of our treatment selection overall. So let's start with fluids. Why fluids? Well, there's the obvious, which is that a lot of these patients with vomiting and diarrhea will be dehydrated. And from a general health point of view, this needs fixing. The other important thing in pancreatitis is to maintain pancreatic vascular perfusion, so blood flow to the pancreas. This is because the pancreas is exquisitely sensitive to reduced perfusion, and this is known to lead to pancreatitis. So we really need to support the circulation to prevent this happening, to prevent worsening of our disease. Now, these guys can benefit from having their dehydration level calculated. Why? Well, most of us chuck everything on twice maintenance initially, so 4 mils per kilo per hour, give or take. If we calculate it, that's enough for a patient with about 5% dehydration, which is about what we have on clinical exam if we have detectably tacky mucous membranes. So for those guys, twice maintenance is perfect. If we have a skin tent, then that equates to more. That's about 7% dehydration, which equates to roughly 2.5 times maintenance, give or take. So that's kind of a rule of thumb. But monitoring and changing rates dependent on response is mandatory, really, in these guys to get the best resolution. Duration of fluids is also really important. It really needs to be 24 hours minimum, and realistically, it should be kind of 48 to 72 hours. And then you have to choose your fluids. Now, this is really an easy choice. It's going to be Hartmann's pretty much every time. Why? Well, it contains an isotonic mix of electrolytes that will go a long way to fix the changes we discussed previously, for starters. You'll probably need to add more potassium. And the BSAVA formulary has a really handy table under potassium chloride to calculate how much you need to add. If you can't measure your blood potassium in-house, then add the maintenance amount of potassium as a minimum, which is 20 millimoles per litre. Either you can take account of how much potassium is in the Hartmann's already, which is about 5 millimoles per litre, and make up the difference, or you can just completely reasonably treat Hartmann's like saline and add the full recommended supplementary volume for sodium chloride to your Hartmann's. Both will be fine. Obviously, make sure to mix the bag very well, though. Hartmann's is also theoretically advantageous as it's an alkalinizing fluid. An alkaline environment, as we previously discussed, slows down the activation of trypsinogen, and so theoretically this might reduce worsening of pancreatitis. Certainly in humans, they've demonstrated that a reduction in systemic inflammation when Hartmann's was used rather than saline. In very severe cases of acute pancreatitis, where the patient's in shock, then you can also use colloids as part of your fluid resuscitation. Obviously, if your patient's in shock, then the odds either you can use colloids or you can use your crystalloids at shock doses. Normally, we would recommend giving your fluid boluses in boluses of kind of 10 mils per kilo and rechecking to assess rather than just going straight for the 90 mils per kilo that's cited as the shock doses. If you are using colloids, then these work by pulling fluid from the intracellular space, and so this can worsen cellular dehydration, and as such it is important to maintain administration of Hartmann's or equivalent alongside to compensate for this. And then there's analgesia. Why? Well, the first answer here really has to be welfare. Pancreatitis is a seriously painful condition in people and appears to be in dogs too, and so not giving analgesia is not really an acceptable course of action. Improved comfort will also improve our eating and drinking, which does have prognostic significance in these patients, which we'll come to shortly. What are the choices? Well, I'd always start with an opioid for pain relief. If the pain is mild, then I'm happy with buprenorphine. If it's moderate to severe, then I would go straight for the methadone, but always an opioid. With our opioid, I would almost always add paracetamol. The only exception really is if there's liver disease as well, so if your hepatic enzymes are really markedly raised. Vomiting and diarrhea are not really contraindications to paracetamol in dogs, and the IV prep particularly is inexpensive and appears to be very, very effective. And paracetamol is, incidentally, is also a drug that I use a lot in cases of chronic pancreatitis in its oral form, so as in the form of PARD LV, which a lot of you will have in practice. If that's not enough for pain relief in the severe cases, then constant rate infusions of ketamine and or lidocaine are going to be your next option. These can be given with or without loading doses, and rates are listed in the BSAVA formulary. And one final drug is gabapentin. This is classically used for neuropathic pain, so a lot of you will have used this for neurological pain. But gabapentin is also known to reduce substance P production, and substance P has been shown to contribute to pain in acute pancreatitis. So the use of gabapentin might not only be an adjunctive pain relief, but might also have a primary effect on reducing discomfort in pancreatitis. What do we not use in pancreatitis? Well, it's mainly non-steroidals. We don't reuse them for two reasons. This is first because the patients often already have vomiting and diarrhea, which is a contraindication to non-steroidals in itself, but also because non-steroidals are suspected to predispose to and worsen pancreatitis. Incidentally, there is also no proven benefit of using steroids in acute pancreatitis, although this doesn't appear to be harmful. The one exception to this might be immune-mediated disease, so immune-mediated pancreatitis in Cocker Spaniels, although more work is needed on this before we start recommending it specifically. Antiemetics and gastroprotectants are another set of drugs that we commonly use in pancreatitis. The need for these is pretty self-explanatory. We'll come on to diet and eating next, but it follows fairly logically that if a patient with pancreatitis feels nauseous, they're considerably less likely to eat spontaneously. Nausea in pancreatitis is likely to be multifactorial. We have the peripheral causes like ileus or pancreatic distension and local inflammation and peritonitis. On top of that, we also have centrally mediated nausea as a result of the pro-inflammatory cytokines acting directly on the chemoreceptor trigger zone in the brain. Management of the nausea in pancreatitis therefore has to take account of both of these. These days, option number one is going to be meropetant. This is a neurokinin 1 antagonist that acts directly on the chemoreceptor trigger zone, but also acts peripherally. It has no prokinetic effects whatsoever, unlike some of the other antiemetics that we've used in the past. And so it can be safely given even if you're waiting for confirmation of your diagnosis by way of spec-CPL or alternative. Like gabapentin, it also inhibits substance P and therefore might also have some local beneficial effects via this mechanism. Other antiemetics you can try additionally include the likes of ondansetron, which is effective but relatively expensive. The one really to avoid is metoclopramide. Metoclopramide is a dopaminergic antagonist with reasonable prokinetic effects where gastric emptying is concerned. The issue with metoclopramide is that dopamine infusions have been shown to improve outcome in models of pancreatitis, potentially due to improving pancreatic blood perfusion. It follows, therefore, that antagonizing this in the way that metoclopramide does has the potential to worsen the pathology. In view of the wide availability now of meropetant and its good efficacy, metoclopramide no longer really has a place in the treatment of pancreatitis and can't be recommended. Gastroprotectants and prokinetics, as we'll lump them together here, are important adjunctive treatments. We want to use them partly to reduce the risk of gastric ulceration, but also because there is evidence that these drugs can also reduce pancreatic inflammation by a mechanism that's currently unknown. Now, probably the best choice as a gastroprotectant is going to be omeprazole. This is available either in an oral prep or IV, although the IV prep is now pretty cumbersome and has quite a large volume. An alternative is a drug called pantoprazole, which is dosed at the same dose rate, which is about 1 mg per kg. And this is available from human pharmacies and is similarly priced to the old omeprazole. Now, the formulary still lists omeprazole and pantoprazole as once-a-day drugs, but actually there's now very good evidence that using these drugs twice a day, BID, at the same dose at a mg per kg is much more effective than once a day. And so this probably should be our kind of regimen of choice for using this now. The other drug that's commonly used is ranitidine. This is an antihistamine drug that has, if we're being honest, a pretty poor effect with respect to increasing gastric pH, although there might still be a mild effect. Its other effect that can be helpful, however, is that it also has mild prokinetic effects. And this is due to its acetylcholinesterase inhibitor action, which increases proximal gastrointestinal motility. It's important to note that its kind of sister drugs, cimetidine and famotidine, don't have this action. You won't get the same prokinetic effects with those drugs. Now, a significant number of patients with pancreatitis will have ileus as a result of local inflammation and anorexia. And therefore, even in the face of better gastroprotective drugs like the proton pump inhibitors, like omeprazole and pantoprazole, there is still a reason to give ranitidine alongside this for its pro-motility action. Now, moving on to diet and nutrition. Until relatively recently, the advice for feeding in pancreatitis was to withdraw food for a number of days initially. This was based on the assumption that eating would stimulate pancreatic secretion and therefore cause worsening of pancreatitis by increasing enzyme production and release. Now, the problem with this assumption was basically that it was wrong. In fact, secretion is already reduced in pancreatitis, irrelevant to feeding, and physiological enzyme release doesn't appear to have any impact whatsoever on development or perpetuation of pancreatitis. Add to this that the gastrointestinal tract requires food passing through it for its energy source. Now, enterocytes don't take their nutrients from the blood, as do most cells within the body, but instead take amino acids directly from the lumen. Lack of food means lack of energy for these cells, which leads to increased enterocyte sloughing, increased inflammation, and poor healing of the intestines. And then finally, all of these patients are often in negative nitrogen balance with a protein energy deficit. They really require feeding. The literature says they should be fed within 48 hours, but to be honest, if I can control the vomiting, then I'd like them to be fed within, realistically, within 8 to 12 hours. So that's 3 reasons why we need to feed and why we should not be advocating pancreatic rest. With the availability of meropitant now, Cerenia, we also have better control over vomiting, and therefore the ability to feed enterally earlier is also available. The only exception to this is if the patient's vomiting intractably, whereby feeding is not possible. But what if they won't eat? Well, if you get to 2 days in hospital, or if the patient's been anorexic for 5 days already, then realistically it's time to place a feeding tube. Now, discussing different types of tube at length is going to be beyond the scope of this webinar, but to cut a long story short, there are 2 sensible options in general practice. The first is to place a nasoesophageal or a nasogastric tube. These used to be a real problem because there was no appropriate low-fat liquid diet available that you could get down them. But times have changed. Royal-Canin have recently released a range of liquid ICU diets, one of which is designed to be low-fat for just such cases. These are thin enough that they pass easily down nasogastric or nasoesophageal tubes, rendering these tubes incredibly useful and very simple and non-invasive to place. The alternative to these is a wider bore esophagostomy tube. You can still use the liquid diets in these, or you can do the old blend with water thing with something like GI low fat. The other big advantage of these tubes is that you can get oral meds down them too. But you need to remember they do require a general anaesthetic in place, which in a critically ill patient can be a significant risk. The selection of diet is unlikely to surprise anyone. We know that high-fat diets have the potential to exacerbate pancreatitis, and so the only real choice is to use a low-fat complete or specifically labelled diet. And Lee is going to talk to you a little bit about Royal Canin's offerings in terms of low-fat diets once I've finished speaking to you. Now, if the patient's eating of their own accord, then a product like Royal Canin GI Low Fat is going to be your perfect choice. Some plain fish or chicken as a tempter is also fine in the early stages, of course, but GI Low Fat really is my choice from beginning to end in all but puppies, where a low-fat diet is not going to be appropriate for growth. In puppies, a balanced intestinal diet is going to be better. In adults, however, low-fat diets also have the benefit of increasing motility by reducing gastric emptying time, and so you get a dual benefit from using this style of diet. How much should we feed initially? Well, the studies that have shown improved outcomes with early enteral feeding have found that the full resting energy requirement is not necessary to confer this benefit. So as such, it's perfectly reasonable to start with small meals and work upwards. If we're tube feeding, for example, we try to work up to resting energy requirement over about 5 days, 3 to 5 days, with initial daily intake of around 20 to 25% of resting energy requirement. This will reduce the potential for side effects such as vomiting or regurgitation, and may also reduce the postprandial abdominal pain that we suspect may be present in some dogs with pancreatitis after they eat. Other suggestions for treatment and dietary treatment have included things like probiotics and specific amino acid supplementations. However, a recent study in people actually found that the people in the probiotic group had a 2.5 times increased likelihood of dying than those who weren't given probiotics. And so at present, we really can't recommend giving probiotics to these patients. There's also not really any evidence at all for any other supplements that might be available. Now, the last thing I'm going to talk about quickly is fresh frozen plasma. The theory here is that plasma contains coagulation factors and proteins such as anti-inflammatory proteins and alpha macroglobulins. The alpha macroglobulins, as we mentioned before, are the proteins that clear activated trypsin from the bloodstream. And therefore, supplementation of these via a plasma transfusion is of theoretical benefit. The same goes for coagulation factors in cases where DIC is suspected. The problem is that there's really no evidence of efficacy whatsoever. And this isn't only in dogs, but actually it's also in the studies in people as well. There's no evidence at all. That said, in very severe cases with a suspicion of DIC, plasma has anecdotally been of benefit and does remain a consideration in the most severe of cases of pancreatitis. So, final notes. We've concentrated very much on acute pancreatitis. But it's important to note that really with acute pancreatitis, it isn't over when it's over. Once they've recovered, these patients should then be treated as potential chronic pancreatitis cases. That means a low-fat diet moving forward, and also education of our owners to recognise the clinical signs nice and early so we can intervene if another acute flare-up occurs. There are also other considerations. A small but significant proportion of dogs with chronic pancreatitis can develop diabetes mellitus, possibly as a result of chronic inflammation and fibrosis and subsequent destruction of the beta cells in the pancreas. Dogs should be monitored periodically for blood glucose and glucosuria, and owners should be advised to monitor for the evidence of polyuria, polydipsia, and polyphagia that we associate with diabetes mellitus. The other condition that should be considered is EPI, is exocrine pancreatic insufficiency. There is a significant functional reserve where pancreatic capacity is concerned, and so 80 to 90% of the pancreas needs to have been destroyed for clinical loss of function. Many dogs with chronic pancreatitis will never reach this level of functional loss in their lifetime, and so won't develop EPI. However, a proportion do. And any dog that begins to lose weight despite eating and who has a history of pancreatitis should be screened for EPI by way of a TLI measurement. Ideally, this should be done when the dog's not experiencing a flare-up, as this might increase your TLI results. So, That brings to the end my part of this, other than questions. I've already had a couple of questions sent through to me by Lee, which is great. In the meantime, I'm going to pass you over to Lee, who's going to have a quick chat to you about Royal-Canin's offerings in terms of diet, including GI low-fat and the GI low-fat liquid diet, which I've just discussed with you. Lee.
Thanks, Dan. And we still have 400 people in the room, so thank you for everyone. And I can say that you have covered a lot of ground already, Dan. So thank you very much for that. Can I just ask you to quickly mute yourself, and I'll just go through a couple of slides. My role here is to, answer the question. How do I really feed this case? How do I approach canine pancreatitis patients from, I suppose, a Royal Canin perspective? For this, my primary focus here is acute pancreatitis, or one of those flares, acute on chronic, particularly in the context of a patient with hyperlipidemia. So let's get that really kind of clear from the start. So anyone who has kind of rung our nutritional helpline or had a really meaningful conversation with one of their business managers, anyone within Royal Canin, will know that it's all about precision feeding, but particularly when it comes to supporting ill patients. But amongst all of this precision, sometimes we can get really carried away for fear of doing harm, and we forget that the base requirement of our patients is obviously providing some life-sustaining calories. So in order to survive, the body does need food. So feeding nothing at all, is my message here, is much worse than the crime of feeding a diet which might not have an appropriate medium or long-term nutrient profile. So Dan has rightly called out the traditional NPO for 48 or 72 hours assumption is a woefully inadequate kind of nutritional approach, I would say, particularly when these cases are presented to us quite often at a status of inappetence already. Those really harmful kind of proteolytic enzymes are actually, activated intracellularly in pancreatitis. So NPO really provides no relief from the organ's exocrine functions. So moreover, particularly where the gastric system is challenged, once again, Dan has said this organ gains its nutrients directly from the gut lumen. NPO therapy poses a threat to adverse kind of consequences, and that be lack of motility, villus atrophy, compromised mucosal blood flow, and compromised immunoglobulin kind of levels there as well. So really we're risking a change in intestinal microflora as well, and a lapse in the GI barrier function. And when calories aren't being presented to the starved patient, malnutrition really does become a risk, sending the animal into a catabolic state. So quite similar to most other malabsorption, malassimilation kind of syndromes. If the gut works, do use it. It's beyond those adverse effects, it's less expensive, safer, with less complications, and does allow us much earlier support. And you can do it in practice, so make sure that you feed early, feed enterally, go ahead with progressive reintroduction of nutrients. So once again, feed first, and then we can think about composition, and this is where a concept of what we call a nutritional par nut comes into play. So to define what a par nut is, it might be a little bit of an unfamiliar term to some of us. It's technically defined as a product which is intended for a particular nutritional purpose, to address the nutritional needs of an animal whose process of assimilation, absorption, or metabolism is temporarily or irreversibly impaired. So that's kind of the technical definition. And it's one piece of guidance that we in the commercial kind of pet food industry have as a rule book, if you will, which sets clinical diets aside from life stage or maintenance diets. And there are a total of 18 par nuts, and each of which reflect on a large body of evidence which demonstrates a clear nutritional benefit to our patients in feeding a corresponding diet. So this is all background, of course, but the National Research Council have defined, in reference to the regulation of lipid metabolism in the case of canine hyperlipidemia, a low-fat diet is, once again, defined as one with less than 43.2 grams of fat per megacalorie. And that for royalcanin is interpreted as a diet which is no greater than 20 to 24% of total calories delivered from that diet from the fat composition, the fat element of the diet. So energy, of course, comes from fat, protein, and carbohydrate. We want less of that energy from fat. So I can see you all jumping up and reaching for your royalcanin product book. But yeah, it's really good to put these diets alongside each other based on kilocalorie levels. So I've done it for you in making those comparisons. What's plain to see here is that 3 diets jump out as particularly low in fat, and they're obviously named appropriately: gastrointestinal low fat. But here you can see we have a bit of room to move if we're using the official NRC, that National Research Council rulebook, where we're looking for diets which are less than 43 grams per megacal. So you can see that hypoallergenic wet downwards can be interpreted as useful for canine pancreatitis cases. However, as I said earlier, royalcanin at least goes that extra step to calculate where the calories are coming from. And if we put things into perspective of fat energy ratio, we can see once again that only those 3 diets there fit into that 20 to 24% bracket. So my golden rule of thumb is that your patient has hypertriglyceridemia or hyperlipidemia, which is obviously a reported risk factor, as Dan has said, and cause for recurrence of signs. So best to reach for that best-in-class formula, which really is formulated to control those blood levels. So remember the primary condition for which these diets are formulated, and know that we do have some room to move. Once again, particularly if you're looking to test your patient's fat sensitivity, particularly if you're feeding in the longer term and have other risk factors to control, or other concurrent conditions to address. So yeah, let's return to our patients and our priorities. First of all, of course, yes, address your hyperlipidemia. So you've got a big tick with that by means of feeding a low-fat formula, a balanced formula. Consider any incidences of dietary indiscretion, knowing once again, particularly when we're dealing with recurrent flares or chronic cases, sudden high-fat meals or return to a fat-dense ration can obviously make things troublesome for these cases. So yes, make that dietary change to a lower fat diet, or keep the animal completely compliant to a lower fat food. Get them out of the trash basically as well. Thirdly, possibly in the longer term, start adapting your recommendation according to concurrent problems. So we know that obviously obesity, diabetes, PLE, even EPI will have kind of some different nutritional priorities to address. But let's always remember, as Dan has pointed out, that anorexia is our primary clinical sign in pancreatitis. So a lack of voluntary food intakes really does need to be addressed, particularly where we've seen that compromise for over 3 days, 3 to 5 days. You can see a nice kind of crib sheet there to assess risk in your patients, and decide when we're going to proceed and place that tube. So I'm sure none of you see these formulas as a surprise. The RER kind of calculations which we should use, particularly when we're reaching for our tube. So do so, or re-establish your RER over a 3 to 5 day period, incrementally up to 100% as per kind of charts such as these. And yeah, as Dan's kind of mentioned, the ICU product does come in handy in not creating a mess as well. And yeah, you'll have to lean less on blenderizing the GI low-fat wet product, and we can get that down a tube which is as little as 3 or 4 gauge French. So those are the new diets on the block. So that's pretty much it for me from a nutritional standpoint. Let's recall the frustration or the disclaimer, I suppose, that each case is obviously an individual and you may need to bend and shape your nutrient profile and your recommendation throughout the disease course. There's no ideal diet, I suppose, for supporting pancreatitis as a syndrome in itself or in its entirety, but we do know that high fat is a risk factor for both pancreatitis and hyperlipidemia, and that's really what these products are about. So that's, I suppose, it from a formal presentation. I'm just looking at our time as well, Dan. We've kind of run over a little bit, but once again, kind of maintaining a lot of interest amongst our attendees. If I can take you off mute and ask you a couple of questions. You still with me, Dan?
Yeah, I'm still here. Can you hear me?
Excellent. Got you there. And I can see a flurry more of questions come through just while I was talking there. So just, I suppose, to get us kicked off, how do you or can we distinguish between acute and chronic pancreatitis based on anything but histopathology? There's a couple of kind of early questions. What's your time threshold in distinguishing between acute and chronic? And once again, also, do clinical signs alter? Any thoughts?
So the honest answer to that really is that clinical signs on their own aren't really enough to differentiate between acute and chronic pancreatitis. So if you look at the studies of histopathological assessment of dogs with pancreatitis, then the vast majority had chronic pancreatitis. So it was about 90% of the dogs that were looked at that had pancreatitis had chronic pancreatitis. Only about 10% had only signs of acute pancreatitis. So the vast majority should probably be considered to have chronic pancreatitis. In terms of ongoing management, in the majority of, or in all cases, if the dog's presented once with acute pancreatitis, then I would assume ongoing that it had chronic pancreatitis and treat it with a low fat diet and continue to monitor for things like diabetes and EPI going forwards.
Mm-hmm. Just picking up on your diabetes mention there, there was Grace asked, is it possible for a dog with subclinical chronic pancreatitis to be presented with diabetes? Do you have any experience of that?
Yeah, so it's absolutely possible. There is certainly an association between diabetes mellitus and pancreatitis, and actually which one comes first is a really difficult thing to assess. If you look at kind of all the studies and the investigations that have been done, it's still not clear whether diabetes comes first or pancreatitis comes first in a lot of cases, but certainly in chronic subclinical pancreatitis, then diabetes mellitus can certainly develop. And if you've got a case of diabetes that's not quite as responsive to insulin as you might expect, then investigations into the possibility of pancreatitis would certainly be a sensible approach.
Mm-hmm. Something's crumbling. Yeah, all of your talk of blood measures, TLI, CPLI, CPL, raised a lot of kind of questions relating to the use of these markers as markers of chronicity as well, and also whether or not we might use these to monitor your progress with disease management. Any thoughts on that side?
So the problem with chronic pancreatitis is that there's really no good tests available at the moment to identify and detect chronic pancreatitis. So all of the tests that we've discussed really are only discussed in the context of acute pancreatitis, and there's nothing at all, whether it be blood testing or imaging, that can really identify chronic pancreatitis. There's been various investigations into things like CT angiography in pancreatitis, but even those are pretty inefficient at detecting chronic pancreatitis. I can't remember what the other half of your question was, Lee. Sorry.
Are we not only reflecting on chronicity, but also being able to monitor progress?
So in terms of monitoring progress, the one that most people use is the SPEC CPL. At the moment, there is no evidence that monitoring kind of a trend in SPEC CPL will assist with monitoring of progress. So trending down doesn't necessarily indicate that our pancreatitis is improving, in the same way that trending up doesn't suggest that it's worsening. So at the moment, repeated measurements of SPEC CPL or any other pancreatic markers aren't really indicated. The only thing that's been shown to potentially have a prognostic or an indication of how well they're doing is the C-reactive protein, which has been shown to reduce as pancreatitis improves. So that would, if you wanted something to monitor progressively, that would probably be the best option.
Mm-hmm. Great. Francesca asks, do hemolysis, lipemia, and icterus influence the SNAP test, which you mentioned, in the same way as SPEC CPL?
Yeah, I think I accidentally misspoke during that. I think I stumbled over my words. So, hemolysis, lipemia, and icterus don't at all, or have not been shown at all, to affect the SPEC CPL. Mm-hmm. The SNAP test is effectively the same assay as the SPEC CPL. It's just as an in-practice ELISA, and so it shouldn't be affected by hemolysis, lipemia, or icterus. That said, there aren't any studies that have been done to prove that, but if we assume that the SNAP is relatively similar in performance to the SPEC CPL that you can send off for, then they shouldn't have any effect at all.
Mm-hmm. Great. I have an answer, but I'd also be interested to hear yours. What about obesity or satiety diets, which are obviously both, low in fat? Any of kind of weight management diets are. Do you have a thought on using these, particularly in the case of an overweight patient?
So there's a huge variety of these diets available from companies like RoyalCanin or Hills or various other companies, and so it's difficult to make a kind of all-encompassing statement. I think making sure you look at the fat content in terms of dry matter is important, but in terms of management, then any kind of low-fat diet is going to be preferable, and certainly looking at the fat content specifically is important. But if you've got a patient that's very overweight and you're looking for weight loss as well as management of pancreatitis, then I would probably personally I would look at diets like GI low fat or similar, and just reduce the volume of food fed rather than looking at other diets. But Lee may have a more kind of molecular, I suppose, answer to that question.
Yeah, I'd agree. From a practical standpoint, yes. It's worth mentioning that previous to having formulas like this, obesity and satiety products, or even diabetic products, probably were the first line for hyperlipidemic cases and pancreatitis cases. But what we need to make you all aware is that, yes, of course, it is reduced in fat on a dry matter basis, but if we take it back to, once again, fat energy ratio, you'll find obesity and satiety diets are actually closer to 30% or so. So they may not be as low fat as you might first intend, and also they do kind of adapt with higher levels of fiber, which can also influence the, gastric performance and transit time, motility, etc. So we don't want to interfere with any malabsorption syndrome particularly in those early stages of stabilization. So maybe for long term, that might be something that we'd work for, but in the short term stabilization, I'd still go for, as you've said, the GI low fat. Staying on diet as well, where we have EPI and pancreatitis occurring concurrently. What's your strategy, Dan?
With regard to diagnosis, do you mean?
Sorry, on diet, what dietary needs, Eleanor asks.
So, I mean, the issue when you've got EPI is that your pancreas is unable to process fat as well as other proteins because you've got a lack of pancreatic enzymes. And so, from a symptomatic point of view, with respect to diet, then actually things like low-fat diets also have an advantage because you're not giving the dog, you're not forcing the dog to process as much fat as would be present in a normal diet. Now, you have to be careful to make sure that the patient's receiving enough calories because obviously their ability to digest and assimilate calories and energy generally is reduced. But from a symptomatic and an owner-driven point of view, then the low-fat diets like GI low-fat are perfect because they put the dog under less pressure to digest. And so you're going to get less steatorrhea, you're going to get less colonic irritation and inflammation because you've got less undigested fat in there. Obviously, if you've got EPI, you need to be supplementing with pancreatic enzymes. But even with the pancreatic enzymes, you're unlikely to be able to assimilate and digest all of the fat in a normal diet. And so even with the pancreatic supplementation, we would probably still recommend a low-fat diet, whether it be GI low-fat or CHAPI or another alternative.
Brilliant. Thank you. Okay, looking at time and the number of questions, know that any of the questions that we have had that we haven't answered, I'm going to annoy Dan after the presentation to answer, and we'll get back to you over email. So that's the rest of the week planned for you, Dan. But one, I suppose, nice big question to finish up with. How would you approach treatment of an acutely presenting dog where a client is in a difficult financial situation and unwilling to spend money on diagnostic tests? So I suppose, what's your empirical?
Gosh, that's a difficult question. I guess to an extent it depends on how financially pressured they are. I think to an extent, you have to rely on your own clinical acumen to decide what the best approach to that is. If you wanted to perform a single test to rule out pancreatitis or rule in pancreatitis, then probably rather than running your amylases and lipases and SNAP CPLs, then I would probably suggest just sending off for a quantitative measurement of either SPEC CPL or DGGR lipase or whatever your routine laboratory assays. Obviously, you have to consider whether there's a likelihood of a GI foreign body, and so you have to consider whether you need to still continue to radiograph or similar. But purely with respect to pancreatitis, if I was going to run one test, then it would probably be a SPEC CPL, because that's realistically going to give you the most accurate and the most reliable assessment of your pancreatic inflammation without wasting any financial ability that your client has on other tests.
You're not getting that scope out then. I want to give you a big clap, Dan, for particularly rising to the challenge of this very complex case that we do see quite frequently in practice and quite often struggle with. Thank you all for coming, wherever you are in the world joining us from. Many thanks.
Thank you. Bye-bye.
Good night.
지금까지 댄 톰슨 수의사의 강의였습니다. 개의 췌장염 진단 및 저지방 식이의 급여에 대해 실제 임상에서 가지셨던 의문들이 많이 해결되셨으리라 생각됩니다. 이번 강의에서 언급되었던 제품들 중에서 ICU 제품과 가스트로인테스티널 모더릿 칼로리 제품은 아직 국내에 출시되어 있지 않습니다. 그 중에서 ICU 제품은 튜브급에 이용할 수 있는 완전 액상 제품으로 내년에 국내에 출시될 예정입니다. 2018년도 첫 번째 웨비나는 ICU 제품과 관련된 중증 질환에서의 엔테럴 뉴트리션에 대해 방송될 예정이니 많은 참여 부탁드립니다. 마지막으로 웨비나 수료증에 대해 안내드리겠습니다. 웨비나 수료증을 원하시는 분들께서는 오늘 웨비나가 종료된 후 설문조사창에서 성함과 이메일을 남겨주시기 바랍니다. 남겨주신 이메일로 웨비나 수료증을 보내드리도록 하겠습니다. 올 한 해 여러분들의 많은 관심과 성원에 다시 한번 깊이 감사드리며 2018년도에는 보다 나은 모습으로 인사드리도록 하겠습니다. 감사합니다.
저기 고양이 한 마리가 보입니다. 고양이는 세상 천지에 못 오르는 곳이 없고 못 듣는 것이 없죠. 하지만 고양이에게도 꼭 필요한 게 있습니다. 안락한 집과 건강한 사료를 제공해줄 집사죠. 훌륭한 집사가 된다는 건 결코 쉬운 일이 아닙니다.